Hi, everybody. Welcome back to our image critique series that I'm putting together. Today, we're going to go over wrist x-ray. So the reason we're doing this is I want you guys to be able to see what an x-ray should look like when you're done with it. It's not going to look like that all the time, and it's going to take a lot of practice. But I want you guys to be able to revert back to this and compare your work to what I'm showing you, and make sure that you're getting closer to that every time you do take an x-ray. Anyway, that's why I'm doing this. We're going to use the same acronym, the PACEMAN acronym. It's just a acronym that we use to critique an image and make sure everything is there that needs to be there, and it looks like it's supposed to look. I'm going to add this to every video just so you guys are aware of what it is, and you'll become familiar on what to look for on every x-ray that you take. So let's start with an elbow. Here we do a 3-view elbow, which is an AP projection, an external oblique projection, and a lateral projection. And elbows can be tricky. It has a lot to do with having the right angle of the elbow itself against the image receptor. You want to be able to see into the joint spaces. So it's really important that you have your elbow on a very similar plane on every image. And you can revert back to my positioning video on that, where I talk about your plane of your arm when you take an elbow x-ray. So this is an AP elbow. It's a left elbow. I mean, we can tell it's a left because it's marked as a left. But always remember that the radial head right here is always on the lateral side. So it's on the thumb side. And you can look at that and realize that, okay, that's on the thumb side and that's on the left side, so that's a left. Okay. So let's kind of go through our acronym through each image, and we'll see what we're dealing with here. So position-wise, this elbow is in a good position. Okay. There's no rotation per se. We're able to see both epicondyles, both medial and lateral, which are parallel to the image receptor. Okay, we can see a third of the humerus right here and a third of the proximal radius and ulna, which is what we want to see. So position-wise, we're in really good shape. Okay, area, yeah, we can see the area that we need to see. All right, we've got good skin margins on both lateral here and medial. So yeah, and we've got a third and a third. So area-wise, yeah, we haven't cut anything off. We're able to see the entire elbow joint. So that's a great job. Collimation. We can see collimation lines right here and right here. So collimation on this x-ray is fabulous. It's nice and tight. We're still able to see what we need to see, but we're not seeing more than we need to see, which I've talked about a bunch. The more you collimate, the better your image is. So yeah, very, very nice job collimating this image. Marker, yep, we've got a left marker there, and it's placed on the lateral side, so we're good. Okay. So aesthetically speaking, it's a great APL elbow image. Like I say, we're able to see everything that we need to see. We've got good contrast. We can see the periosteum really well, and the difference between the periosteum and the soft tissue is well displayed. Our soft tissue edges are nice and sharp. We can see the intermedullary cavity on every bone, which is nice. We can also see some bony trabeculae. You can see these lines throughout the bone. If you can see those on a bone, your contrast is really, really good. So Yeah, definitely a really nice AP elbow x-ray. So let's move on to the external oblique. Now with elbows, you can do either an external oblique or a internal oblique. I feel like that you can see more with the external oblique. Doing the external oblique, it's going to open up the space right here between the radius and ulna. Okay, you can see that we've got a nice joint line between the radial head and the ulna right here. We can see the uh, radial tuberosity right here. So yeah, this is a nice external oblique. You can see the difference between the AP where we've got some superimposition right there, and when we turn out to the external oblique, we're able to open that joint space. So it's really nice. Now, in both these images, both the AP and the oblique, we can see good joint space between the radial head and the humerus, as well as the ulna and the humerus. Um, we can see the olecranon process coming off the ulna right here into the olecranon fossa. So yeah, position-wise, this is really nice. We're able to see what we need to see. So area-wise, yeah, we've got a third and a third, so good job there. Collimation-wise, again, great collimation. We got a collimation line here and a collimation line here. It's almost perfectly done. So very very good. Exposure wise, yeah, it's a very nice contrasty picture for an elbow X-ray. Again, we can see the intermedullary cavity really well. We can see some bony trabeculae again. And the periosteum is well defined, which is the bony edges as compared to the soft tissue. Again, we can see soft tissue ungulations as well as good lateral and medial skin margins. So uh, yeah, really nice exposure. It's marked well with a left. We know it's a left, and I told you another way to figure out which elbow that is. Just remember that the radial head is on the thumb side. So, uh, aesthetically speaking, this is a really nice external oblique X-ray. Definitely one that's passable and very diagnostic. So, this is what you're looking for, guys and girls. Um, okay, very very nice. All right, let's move on to the lateral now. All right. Oh, sorry, I'm skipping ahead. So we've got a left lateral. We need to kind of pretend that we're looking down on the patient, and that is the patient's left arm coming out and turning inward. Okay, that's how we know that it's a left. One thing I do want to mention, we've been doing fingers, hands, wrists, forearms, and those are all hung from the fingers. Once we hit the elbow, we're starting to hang from the shoulder. So you should have your humerus on top and your radius and ulna on the bottom. Okay, just like that. All right. So position wise, it's really nice. We've got a 90-degree angle of the elbow here. Uh, yeah, it's great. We've got at least a third, if not a little bit more, of the proximal radius ulna and the distal humerus right here. So yeah, very, very nice position wise. We have a good joint line right here between the ulna and the humerus. Okay, our condyles are pretty well superimposed. We've got a little bit of overlap right here, uh, which is definitely not enough to redo this image. So it's pretty good. And the way you combat that is you can angle your tube usually a little bit toward the head of the patient to line those up a little bit more, but you're really picking at straws at that point. So yeah, this is a really nice image. Okay, there is an image of the radial head. If you have a provider that wants you to do a radial head X-ray, is all you're going to do is you're going to angle your tube 30 to 40 degrees towards the patient's head. Because what that'll do is that'll elongate the radial head right here, just so we can see it a little bit better. They very, very seldom do that x-ray. I just want you to be aware that that is something. If you ever run that or have a radiologist wants you to do a radial head picture, let me know and I'll walk you through it. Okay, let's go on through our thing here. So we're able to see the area really well. There's nothing cut off that we need to see. Collimation wise, your collimation is going to be a little bit open on these, just for the fact that we need to see up here and we need to see clear over here on the radius and ulna. Okay. But all in all, yeah, it's collimated really well. You know, you've got a nice square there with your elbow joint right in the middle. So very, very nice. So exposure, again, really, really nice exposure. You know, our intermedullary spaces look really, really well defined. Our periosteum and soft tissue are well defined as well. Our joint lines are nice and sharp. So exposure wise, really, really nice exposure. This exposure was done at like 55 or 60 kVp at probably 5 mass. Yeah, really, really nice. Let's see. Marker. Yep, we're marked. You can put that marker either here or up here in the crease of the elbow, just as long as it's not covering anything. So aesthetically pleasing picture. Yeah, it is. It's a really nice elbow series. So when you do your elbows, this is what you want to see. Okay, this is a nice professional job, very diagnostic. Any provider, X-ray tech, radiologist would be very pleased with this elbow, and you'll probably get compliments on it. So, all right, I want to talk to you guys a little bit about the fat pads that are present on elbow X-rays. They actually lie on the anterior portion of your humerus right here, and right here on the posterior of your humerus. So when our elbow is injured, you know, some of the cell sign or the fat pad is actually displaced a little bit, which you can see on an X-ray. And sometimes fractures on a elbow are kind of hard to see, especially the inner articular fractures of the radial head. So the radiologists and providers really count on what they call the cell sign. You can see the dark right here, okay, and right here. It kind of looks like a cell, right? That just means that the fat pad has been disrupted in some way, and it usually says that there's an effusion in that joint, or there's fluid in that joint, and sometimes can mean that there is an inner articular fracture of the radial head, usually that sometimes you can't see, but this will give you a good indicator that there is a problem with the elbow, even though you can't see it on the X-ray. At that point, you know, they usually order a CT or an MRI to figure out what is going on with that elbow. But the cell sign is very important. That's why it's so important that you get a good exposure on an elbow. You need to get a good exposure on everything, but a good exposure on an elbow where you can see the fat pads. And when those fat pads are not disrupted, you usually can't see them really well. When they are disrupted and you know what to look for, you can tell that there's a cell sign there, and there's usually something going on with the elbow. Okay. Anyway, I hope that was helpful going through an elbow X-ray. Elbows are cool. I like doing elbows. Sometimes they're challenging just for the fact that it does hurt the patient. But get to where you can do a good elbow. Good elbows are nice, and this is a good elbow. So if you ever have questions about what an elbow looks like, take a look at this video. And I encourage you guys to go through these videos and really, because it can help you learn about X-ray. there's various videos and classes out there that I've put on the Sterling Hub that are informative and there to help you. Okay. Anyway, thanks for you guys watching this. I appreciate it, and we'll see you for the next one, which will be a humorous. So, thank you guys very much.